Hello, and welcome to Electrolytes and Acid-Based Practice for the Boards, Part 1. I'm Alan Yu from the Division of Nephrology and Hypertension and the Jarrett Grantham Kidney Institute at the University of Kansas Medical Center. This is my bio. I have no financial disclosures. And our objectives are as follows. We're going to have a series of what I think are ABM-style multiple-choice questions that will review the diagnostic approach to common electrolyte disorders. For this first part, that's going to be about half an hour, we're going to be talking about sodium disorders and hypokalemia. And in the second part, we'll talk about hyperkalemia and acid-base disorders. So let's launch into the first case. This is a 35-year-old man with bipolar disorder who's maintained on lithium for 10 years and is referred to you for chronic polyuria and polydipsia. He complains that he has to void once every hour, and you can see that his serum sodium is 144, creatinine is 1.9, serum osmolality 292, 24-hour urine is 5 liters, and his urine electrolytes are as shown. And the question is this: all of the following might be appropriate in the management of this patient, except A, thiazide diuretics, B, dietary salt reduction, C, discontinuation of lithium, D, fluid restriction, E, amiloride. And hopefully you got the answer, which is fluid restriction. This is the only one that's inappropriate. So let's back up and think through the workup of this patient. And there are a couple of ways of approaching this, but we're going to start by looking at the differential diagnosis of polyuria, which we define as a urine output of more than 3 liters per day. So there are a couple of ways that you can increase your urine output. You can either have more water that needs to be excreted, which we call a water diuresis, or you can have more osmotically active substances that need to be excreted, and water follows along with that. And we call that an osmotic diuresis. The way we distinguish between this is by looking at the osmolar excretion rate. How many osmoles are excreted per day? And this is just the urine output multiplied by the urine osmolality. In a normal individual on an average American diet, the osmolar excretion rate is somewhere between 500 and 1,000 milliosms per day. So this is normal. Therefore, any additional water that needs to be excreted would be free water. So that's a water diuresis. If the osmolar excretion rate is over 1,000, that's an osmotic diuresis. And the causes of osmotic diuresis include sodium chloride itself, glucose in hyperglycemic states, urea in patients fed high-protein supplements, or other exogenous substances like mannitol. Now, water diuresis can occur either because the patient is taking in extra water, which we call polydipsia, or because the kidneys are unable to concentrate their urine, which is called diabetes insipidus. And if we're able to distinguish this with the serum sodium, we'll see that this oftentimes, polydipsia drops the serum sodium, whereas diabetes insipidus would tend to increase the serum sodium. So in this particular patient with polyuria, osmolar excretion rate, if you multiply the osmolality by the urine output, was less than 1,000. Patient's serum sodium was greater than 140. So this was probably diabetes insipidus, and given the history, probably caused by lithium, which would suggest a nephrogenic diabetes insipidus. Here are some of the common causes of nephrogenic diabetes insipidus, of which the ones in orange are the most common. Don't forget the electrolyte disorders that cause this. Lithium is the most common drug-induced cause. Tubular interstitial diseases can cause this, and this can be mimicked simply by CKD. And the treatment is to treat the underlying cause if possible. Supraphysiologic doses of desmopressin are sometimes helpful. NSAIDs and COX-2 inhibitors, and mechanisms to reduce the delivery of sodium chloride to the collecting duct can also reduce urine output. But the important thing to recall is that one must not restrict fluid because they have an obligate urine output, and so fluid restriction would lead to profound hypovolemia. Okay, on to the next case. A 55-year-old man with colonic carcinoma who undergoes resection of his tumor and diverting colostomy, and because of that, he has a post-op prolonged ileus and needs TPN. And 4 days later, a renal consult is called for hypernatremia. Patient looks euvolemic, but has a sodium of 151, urine osmolality is 480, urine volume is 3.7 liters. And the question is, which of the following is most likely to cause his hypernatremia? Is it central diabetes insipidus, nephrogenic DI, osmotic diarrhea, osmotic diuresis, or excess intravenous saline? And the answer is osmotic diuresis. So if we work through the polyuria differential diagnosis again, you'll see now that when you multiply the urine output by the urine osmolality, you find that it's 480 multiplied by 3.7 liters, which is 1776 milliosmoles per day. So this is an osmotic diuresis. These are the causes. Given that the patient was on total parenteral nutrition and getting a high intake of protein, it's most likely that this was a urea osmotic diuresis. Another way of approaching this is from the point of view of hypernatremia. Now, hypernatremia can be caused by two general reasons, either renal loss of free water or extrarenal causes. And the extrarenal causes include insensible losses that aren't replaced by drinking water, GI water loss, in other words, an osmotic diarrhea, or intake of sodium in excess of water. This doesn't normally happen in adults who are able to sense thirst, but it's been described, for example, in infants. The distinction between these is determined from the urine osmolality. The normal response of the urine to hypernatremia is to release vasopressin and maximally concentrate the urine, which means a urine osmolality greater than 800. And this would indicate that an extrarenal cause is active. If, on the other hand, the urine osmolality is inappropriately low, that would suggest that there's renal water loss, the causes of which are either diabetes insipidus or an osmotic diuresis. And all of this can only occur, the hypernatremia can only occur if there's concurrent limitation of the ability to take in water. So in this case, the patient was NPO, and that was the reason he became hypernatremic. Okay, next case. A 17-year-old woman who is otherwise fit and well and on no medications presents with a history of polyuria since early childhood. So on presentation, she has a serum sodium of 141, serum osmolality of 285, urine osmolality of 210, and a urine volume of 4 liters. After 4 hours of water deprivation, her serum sodium is 146, serum osmolality 298, urine osmolality 250. At that point, she gets 10 micrograms of intranasal DDAVP, and 1 hour later, her serum sodium is 143, serum osmolality of 292, urine osmolality of 585. Which of the following statements could be true? A, she is entirely normal since her baseline serum sodium is normal. B, the water deprivation test is non-diagnostic because water deprivation was not continued for long enough. C, she has central diabetes insipidus. D, she has nephrogenic diabetes insipidus. Or E, she has an osmotic diuresis with washout of a medullary interstitium concentration gradient. And the answer here is C. She has central diabetes insipidus. So let's see why. So she seems to have renal water loss. She has a dilute urine and a low osmotic excretion rate, but her serum sodium is normal. So one can't distinguish whether this is due to primary polydipsia or diabetes insipidus. So the question that needs to be asked first is there actually a defect in urinary concentrating ability? And the way to determine this is to determine the urine osmolality when ADH release is maximally stimulated. So if the patient were hyponatremic at baseline and had a high plasma osmolality, then you could simply look and see whether your urine osmolality was appropriately increased to greater than 800, as we mentioned before. However, many such patients are able to drink enough water to keep up with their water losses and have a normal sodium, as this patient did at baseline. And therefore, one needs to stimulate ADH release with an overnight water deprivation test. And the water deprivation test is only a good test if you can get the plasma osmolality to greater than 295. And if you do so, and the urine osmolality is still less than 800, that's diagnostic of diabetes insipidus. And in fact, that was the case in this patient. Then if you've diagnosed diabetes insipidus, we need next to distinguish whether this is nephrogenic or central. And we ask the question, can the defect in urinary concentrating ability be reversed by a vasopressin analog that acts on V2 receptors, in other words, DDAVP? And it's considered yes if the DDAVP increases the urine osmolality by at least 50%, and no if it doesn't increase by 50%. So in this case, the urine osmolality did increase by more than 50%, so that indicates that the renal tubules are responsive to vasopressin. Therefore, the defect must be that there was inadequate vasopressin release, which is the definition of central diabetes insipidus. Okay, I think this is the last hyponatremic case. A 45-year-old female underwent transsphenoidal resection of a large pituitary adenoma 1 week ago. Immediately post-op, she developed polyuria and was treated with DDAVP for 2 days and encouraged to increase PO fluid intake. She returns with change in mental status, has a seizure in the emergency room, and is found to have a serum sodium of 120. So sorry, this is a hyponatremia case. Which of the following statements about her hyponatremia is true? A, her hyponatremia is caused by inappropriate treatment of DDAVP. B, she has pseudohyponatremia. C, she has central hypothyroidism. D, she has psychogenic polydipsia. Or E, her hyponatremia is due to unregulated vasopressin release from the posterior pituitary. And the answer is E, unregulated vasopressin release. So this slide summarizes the pathogenesis of disordered water metabolism after transsphenoidal pituitary surgery. And it can be divided into 3 phases, and patients can have one or more of these phases at any one time. So immediately after surgery, the first thing that happens from day 1 onwards is an acute secretional arrest. The stalk of the pituitary stops releasing vasopressin, and this leads to hyponatremia and polyuria. And that's what's shown over here in this first phase. So a large proportion of patients will get this. And the appropriate response to this is indeed to give DDAVP. So this was an appropriate treatment. There's a second phase that begins midweek and goes towards the end of the first week, and that is progressive degeneration of the pituitary stalk with release of preformed vasopressin from the neurosecretory neurons. And this leads to the second phase, which starts around the end of the first week and could go as long as 2 weeks, in which patients become hyponatremic. And so this mimics an SIADH. And so this is what happened to this particular patient. And then at the end of this, when the preformed vasopressin has been released from the cell bodies, then we get to the third phase. The majority of people in the third phase come back to normal, but a small minority of patients, about 1% or so, have sufficient loss of neurosecretory neurons that they have inadequate amounts of vasopressin and have permanent diabetes insipidus, and that would be the third phase, about 1%. So this patient was in the second phase, and this is a self-limited event that just needs to be treated with fluid restriction and careful monitoring. Next question. A 45-year-old male smoker presents with confusion and drowsiness, looks euvolemic, and chest X-ray shows emphysematous changes, but is otherwise normal. And so this is a case of severe hyponatremia. Sodium is 116, serum osmolality is 256, and his urine lights and osmolality are as follows: 670 for the urine osmolality. Which of the following is most likely to reveal the cause of this patient's hyponatremia? Is it a water deprivation test, CT scan of the chest, serum protein electrophoresis, echocardiogram, or assessment of daily fluid intake? So I would go for B, CT scan of the chest. So let's go over the differential diagnosis of hyponatremia. When I see a patient with hyponatremia, the first question I ask is the plasma osmolality truly reduced? So is this really hypoosmolar hyponatremia, in which case we can measure the plasma osmolality that's less than 275. If the plasma osmolality is normal, then this is probably pseudo-hyponatremia, a lab artifact that can occur in patients with very severe hyperlipidemia or hyperproteinemia, especially if this, and perhaps only if their sodium is measured by indirect potentiometry. In other words, the serum is diluted before it's measured. Hyponatremia can also occur in the setting of hyperosmolality if there are other osmotically active substances in the serum, particularly glucose and mannitol. And hyperglycemia is particularly common, and for that reason we have a rule of thumb to correct the serum sodium for hyperglycemia by adding 1.6 to the sodium for every 100 mg per deciliter the glucose is elevated. So this patient has clear hypoosmolar hyponatremia. So the next step is to ask the question, is the urine appropriately dilute for this hypoosmolality? The normal response of the kidney to hyponatremia and hypoosmolality is to shut off vasopressin release and maximally dilute the urine. How to dilute? The urine osmolality should be less than 100. And if that occurs, the only common cause of that is primary or psychogenic polydipsia, patients drinking water faster than the kidney can excrete it. There are other causes that generally don't come up in the boards. The most common, second most common, is low solute intake, so-called beer potomania. But most patients have a urine osmolality that is inappropriately high. Usually they have elevated vasopressin levels for one reason or another, and determining their volume status clinically can help us distinguish between them. So there are patients who are hypovolemic due to loss of salt and water, whether it's from diarrhea or vomiting or diuretics or adrenal insufficiency. These can all cause hyponatremia, and they do so because they cause non-osmotic vasopressin secretion. Hyponatremia can also occur in association with edematous disorders, particularly heart failure and liver failure. And in these cases, the body behaves as if they are hypovolemic, a condition we call effective arterial blood volume reduction, which can be either because the cardiac output is low or because of peripheral vasodilation. And it's important to recognize that in both true hypovolemia and conditions that mimic hypovolemia, the kidney would normally respond by lowering urine sodium, usually to less than 20, except if the cause of hypovolemia is salt loss in the urine itself, in which case urine sodium would be high. If the urine sodium is low, it suggests that there's either an extrarenal cause of volume depletion or effective circulating volume depletion from heart failure or liver failure. Finally, those patients who are euvolemic, the majority of them have a condition where vasopressin or ADH is just simply released inappropriately, and we call that syndrome of inappropriate ADH secretion, or SIADH. One condition that mimics this is hypothyroidism that can behave very similarly, at least biochemically, and so that always has to be in the differential. In fact, adrenal insufficiency and hypothyroidism are often unrecognized endocrine causes of hyponatremia, and so this is just to remind me that I should always check a TSH and a cortisol level in any patient with unexplained hyponatremia. So our patient had a very high urine osmolality and was euvolemic, so he probably had SIADH, and given that the chest x-ray looked like he was a smoker with chronic obstructive pulmonary disease, the chances are that this patient probably had small cell lung cancer, and that would certainly be the first thing that one would need to rule out. So here's a reminder of the causes of SIADH: ectopic production by tumors, of which small cell lung cancer is the most common; neurologic causes, almost any intracranial cause pathology can cause SIADH, including meningoencephalitis, strokes, and neoplasms. Pulmonary diseases like pneumonia and TB can uncommonly cause SIADH. Drugs, on the other hand, are a very common cause, particularly SSRIs and other psychoactive drugs. SIADH occurs transiently post-operatively and can also occur in association with very vigorous and prolonged exercise, and so-called exercise-associated hyponatremia, as occurs in marathon runners. Okay, moving on to the next case. Here's an 18-year-old woman with schizophrenia who's maintained on risperidone and presents with a generalized seizure. And her serum sodium is 120, serum osmolality 252, urine osmolality is 90. Which of the following is the best treatment for this patient? Is it 3% saline at 100 mils an hour, 0.9% sodium chloride at 500 ml IV bolus, tolvaptan, stop the risperidone, or fluid restriction? So I think the first step here would be fluid restriction. So if you look at this patient's profoundly hyponatremic, yet the urine osmolality is very, very low. So the patient is putting out dilute urine, but presumably drinking faster than the kidney can excrete water, which is found in primary polydipsia. Restricting fluids would when fluids are restricted, this patient would continue to put out dilute urine as long as the sodium was low, and therefore this would lead to a very rapid correction of the serum sodium by itself. In fact, if anything, the concern is that it might be too rapid. Next, a 38-year-old man was diagnosed with squamous cell carcinoma of the head and neck 2 months ago and has known chronic SIADH. On a routine clinic visit, he is alert, oriented, and feels fine, but reports subtle impairments in his ability to think clearly. So he has a serum sodium of 116, potassium 3.4, urine sodium is 90, potassium is 23, and his urine osmolality is 464. Which of the following would be appropriate in the management of this patient? Hypertonic saline to raise serum sodium by 14 milliequivalents per liter in the first day, 0.5 liter fluid restriction and salt tablets, tolvaptan to raise serum sodium by 2 milliequivalents per liter per hour over the next 12 hours, normal saline at 125 mils an hour, or DDAVP 1 microgram sub-Q. I think the correct answer should be fluid restriction and salt tablets. So when we think about the treatment of SIADH, there are multiple options, including fluid restriction. If you take in less free water, then the serum sodium would be less likely to fall. Isotonic saline, but with a caveat, which we'll get to, I think. Hypertonic saline, or the oral equivalent, which are sodium chloride tablets, urea powder, which basically causes an osmotic diuresis, furosemide, which clamps the urine at isotonic, and so is useful in SIADH patients that have very concentrated urine, and then vasopressin antagonists, usually tolvaptan. In the past, we used demeclocycline, but that's really no longer used. So the important point of this question is the issue of how quickly to correct the sodium. And as I think we're all aware, overly rapid correction leads to osmotic demyelination syndrome. And the population at risk are those who have serum sodium that's moderate to severely low, less than 120, and is relatively chronic, meaning at least 48 hours, like this patient. In terms of how quickly to raise the sodium in these patients, there's still some controversy over it, and these suggestions have fallen over the years, but I still like to use the 2013 expert panel recommendations from Joe Verbalis. I don't think anything's changed in terms of the available evidence since then. And the recommendation is that usually you don't raise the sodium by more than 10 to 12 in the first 24 hours and 18 and 48 hours. If patients are at high risk for osmotic demyelination, including patients who are alcoholics, malnourished, then the limit might be 8 millimoles per liter in a 24-hour period. And so this patient with chronic hyponatremia and very, very mild symptoms should not be corrected rapidly. And so fluid restriction is a reasonable option. In this case, normal saline would not be helpful because normal saline will only raise the sodium if the urine is more dilute than normal saline. It's more concentrated than normal saline, I should say, and this patient's was not. So next, and maybe last hyponatremic case is that of an 18-year-old female college student who runs the Boston Marathon. It's her first marathon, and so she is careful to keep well hydrated before and during the race. But at the finish line, she feels severely nauseated, dyspneic, and has generalized headache. On exam, she's lethargic, dyspneic, and confused. She looks well hydrated. Vitals look okay. but her point of care blood sodium is 112. Which of the following would be the best initial treatment for this patient? Is it a liter of 0.9% sodium chloride, fluid restriction unobserved for 1 hour, salt tablets orally, 100 mils of 3% sodium chloride, or 1 liter of sports drink? And I would go with the 100 mils of hypertonic 3% sodium chloride. So this patient almost certainly has exercise-associated hyponatremia, a very well-described syndrome that presents exactly like this case. And the important thing to understand here, as reported by Almond in New England Journal of Medicine, is that the hyponatremia is dilutional. It's due to excessive drinking of water and or sports drinks, and not due to dehydration. And so what you can see here is that the patients with hyponatremia generally had weight gain during the race. In fact, the more weight gain they had, the greater their risk of hyponatremia. So this is not hyponatremia from dehydration, this is hyponatremia from excessive drinking. Now, the drinking itself wouldn't cause hyponatremia were it not for the fact that the urine is also inappropriately concentrated. In other words, these patients, these individuals have, in essence, an acquired SIADH from whatever consequence of the exercise, maybe the nausea or the fatigue or so on. And so that's why they won't be corrected necessarily with just normal saline, and they need a hypertonic saline to correct. And this patient's the hyponatremia is acute, and they're at high risk of both cerebral and pulmonary edema. And therefore, it's recommended that any athlete with exercise-associated hyponatremia and any symptoms like respiratory insufficiency, confusion, obtundation, nausea, and vomiting be treated with hypertonic saline. And the quick rule of thumb is simply to give 100 mils of 3% over 10 minutes, which is expected to raise the serum sodium by about 2 to 3. And then this can be repeated if the hyponatremia persists hourly with monitoring of the serum sodium. Okay, and now for something different. A 66-year-old female with non-insulin dependent diabetes presents with several days of malaise, lethargy, polyuria, and decreased oral intake. Physical exam reveals tachycardia, orthostatic hypotension, dry mucous membranes, and you can see that her serum potassium is 5.2, bicarb is 25, creatinine is 1.8, serum glucose is 975. After initiating insulin and with 2 liters of isotonic saline, which of the following would be the best treatment to normalize the patient's serum sodium concentration? Hypertonic saline, oral fluid restriction, hypotonic saline, tolvaptan, or salt tablets. So just a quick reminder, the sodium is 135. And the answer is hypotonic saline. So remember, if you have a patient with hyponatremia who's hyperglycemic, they don't have true hypoosmolar hyponatremia. To really understand their true osmolar status, you need to correct for the hyperglycemia. And what the correction is really doing is not saying that your serum sodium measurement is wrong. What it's saying is that you need to understand what would the serum sodium be were the glucose to be normal. And so that's what the sodium will be once you've given insulin and corrected the glucose. And it's adding 1.6 for every 100 mg per deciliter the glucose has increased. Here, the patient's glucose is increased by 875, so we multiply 8.75 by 1.6, add that to the sodium. And now you can see that the patient is actually, after correction, hypernatremic. And the reason the patient's hypernatremic is because glucose causes an osmotic diuresis and loss of free water in the urine. So prolonged hyperglycemia and glycosuria generally causes hypernatremia. But you can't really, but this is disguised by the hyponatremia that's caused by the high glucose. And that's why hypotonic fluids are needed in this patient. Okay, next case, a 74-year-old female with a history of hypertension, hyperlipidemia, and depression. Her meds are hydrochlorothiazide, lisinopril, simvastatin, and sertraline. On exam, she appears euvolemic, and she has a sodium of 117, cholesterol of 220, triglycerides 345, cortisol of 15, T4 0.9, and her urine osmolality is 230 with a urine sodium of 58. What is the most likely cause of her hyponatremia? And the answer is probably E, adverse effect of medications. So this patient has an elevated urine osmolality. She's euvolemic, so it looks like SIADH. We made sure that her TSH and cortisol were normal. And she's on an SSRI, which is a very, very common cause of SIADH. So unless proven otherwise, she probably has SSRI-associated SIADH. Okay, our last hyponatremic case. I think a 63-year-old female with hypertension was started on hydrochlorothiazide 2 months ago and presents with drowsiness, confusion, and hyponatremia. Her sodium is 110, urine osmolality 430. She is initiated on 3% sodium chloride at 200 mils per hour and kept NPO. And 5 hours later, her serum sodium is 124. Mental status is unchanged. Which of the following is the most appropriate next step? Change the rate of 3% saline to 80. Discontinue fluids and initiate tolvaptan. Discontinue fluids and initiate fluid restriction. Discontinue saline and start dextrose and DDAVP, or none of the above. And the answer is D. So this is a patient whose sodium was increased much more rapidly than anticipated. So the patient is at risk of osmotic demyelination syndrome. And in this situation, there's evidence to suggest that re-lowering the serum sodium can protect the patient from the risk of osmotic demyelination. And we do this by switching to hypotonic fluid and then giving back DDAVP to concentrate the urine again. Okay, a few hypokalemic cases to finish off with. A 30-year-old female with anorexia nervosa is found to be hypokalemic. Blood pressure is a little low at 95/45. Serum potassium is 3.2. 24-hour urine has 1 liter with 80 of potassium and 54 of chloride. Which of the following is the most likely cause of this patient's laboratory findings? Surreptitious vomiting, laxative abuse, Barter's syndrome, licorice ingestion, or diuretic abuse? And the answer is diuretic abuse. So when I see a patient with hypokalemia, the differential diagnosis is a shift of potassium into cells, which only usually causes transient hypokalemia, GI losses from diarrhea or vomiting, or urinary K wasting. In the boards, if there's urinary K wasting, they would give you the 24-hour urine potassium, which if inappropriately high is greater than 25. But in practice, you could use the TTKG, which has gone out of favor, or the spot urine potassium to creatinine ratio. If the patient has urinary potassium wasting, we divide it into patients who are hypertensive and have hyperaldosteronism, and those are normotensive or volume depleted, as in this patient. Sometimes hypokalemia is associated with metabolic acidosis. This is unusual and usually suggests either diarrhea, renal tubular acidosis, toluene abuse or glue sniffing, or amphotericin toxicity. More commonly, this is associated with metabolic alkalosis. In this case, the urine chloride is critical. If the urine chloride is low, it suggests that the patient is vomiting. If the urine chloride is high, greater than 40, it suggests that the problem is urinary sodium chloride wasting from the thick ascending limb or distal tubule, increasing the sodium presentations of the collecting duct, where it's reabsorbed in exchange for K secretion. Sometimes the urine calcium can help you in this regard. High urine calcium is associated with a thick limb problem, which if inherited is Bartter syndrome, and if it's acquired is a loop diuretic abuse. If it's low, the urine calcium, Gittelman's or thiazide use. Here, we aren't given, I don't think, the urine calcium, but the high urine chloride suggests one of these disorders, probably not Bartter's because that's a disorder of infancy. Next, the 23-year-old male is referred for workup of newly diagnosed hypertension. He is otherwise asymptomatic. His blood pressure is 155/97, potassium is 3, bicarb is 29, renin and aldosterone are both low, 24-hour urine potassium is 65, which is high. Which of the following tests would be most likely to be helpful? Is it serum metanephrines, Doppler ultrasound of the renal arteries, 24-hour urine aldosterone, 24-hour urine 18-hydroxycortisol and 18-oxocortisol, or 24-hour urine cortisol? And the answer is 24-hour urine cortisol. So in a patient with hyperaldosteronism, this can either be caused by high renin causing a high aldo, so secondary hyperaldosteronism. The most common cause is renal artery stenosis, but this can also occur with a reninoma or in the acute phase of a malignant hypertension. It can also be caused by primary hyperaldosteronism, where the renin is secondarily suppressed, low renin, high aldosterone. And this can be mimicked by the rare condition of glucocorticoid remediable aldosteronism. If both renin and aldo are low, this suggests a condition that mimics high aldo, so either high cortisol levels from Cushing's or inhibition or mutation of the gene that metabolizes cortisol to cortisone, so licorice ingestion or apparent mineralocorticoid excess, or a mutation that leads to overactive epithelial sodium channel, which we call Little's. So that's the differential diagnosis in this patient, and Cushing's is the most common. And this is just to remind you of the workup of these various conditions. This comes up frequently in the board, so it's useful to remember these. Next case is a 19-year-old Asian male who presents to the emergency room with acute onset of flaccid muscle weakness. He's euvolemic and has a potassium of 1.7 and a urine potassium of less than 5. Which of the following would be appropriate in the management of this patient? Is it to replete with 160 of potassium chloride daily, give the peronide, indomethacin, check the TSH, or none of the above? And I think the answer is first check the TSH. So severe hypokalemia like this should suggest to you a cellular shift condition, particularly in this case where the urine potassium is extremely low. So this patient's presentation suggests hypokalemic periodic paralysis. There's a rare genetic form and a common acquired form that's associated with thyrotoxicosis, occurs in young Asian males, and in this case, the potassium recovers either spontaneously or with giving propranolol. The mistake here is to load the patient up with too much potassium that can cause dangerous rebound hyperkalemia. And let's finish with this last case, 67-year-old male with hypertension for 30 years, who's been having worsening blood pressure control over the past year. He had a myocardial infarction 2 years ago and has a potassium of 3.4, bicarbonate of 27. The renin is very high at 7.3, and the aldosterone is elevated. And the most likely cause of this patient's hypokalemia? C, renal artery stenosis. So in this patient, you can see that both renin and aldosterone are high. Here's the differential diagnosis, and the most common cause is renal artery stenosis. Thank you very much for your attention.